But now we're very privileged to move into our last session of this evening. And it's a very, very important topic for a lot of people that are living with cystic fibrosis. And it's the subject matter of living with cystic fibrosis and cystic fibrosis related diabetes. And we're very lucky that we're joined this evening by three panelists that are going to share their insights, their expertise with us. We're joined by Dr. Owen Noctor, who is a consultant endocrinologist. Owen, I'm not going to read all of the letters out that are after your name because we could be here for quite a while, or any of your accolades, but I'll let you introduce yourself in a couple of minutes. We're also joined this evening by Linda O'Shaughnessy, who's a Corey registered dietitian, specializing, I understand, in diabetes, and Siobhan Hatton, who is a diabetes clinical nurse specialist. So this evening, we've got a session with Owen, Linda, and Siobhan. If I could ask everybody that is participating, if they do have questions for any of the presenters, we will leave room. Owen, I know you're up first, but we'll leave room, hopefully about 5 or 10 minutes towards the end of the hour to take Q&A that do come in from the participants from the audience. I'm sure there are particular questions that people might want asked or answered. But without further ado, Owen, I didn't do you a great intro because your blog and your bio stands and speaks for itself, and we'll share it. But thank you very much for joining us this evening. Thanks for taking the time out of your Tuesday night. And yeah, I'll hand it over to you, and you're very welcome. And thanks for going through your presentation with us.
Yeah, great. Okay, thanks very much, Keith. I'm delighted to be asked to speak, and delighted to do it on a Tuesday evening. It's a nice, easy time. We're under no pressure, so from my point of view, I'm absolutely delighted, and thanks very much for the invitation. I'm aware that I don't want to cross over with the other presentations this evening, so I'm going to take some parts of cystic fibrosis related diabetes and go through them. I'm sure I won't answer all the questions you have, so hopefully it'll leave a bit of time for discussion at the end where we can address anything in particular. That's the Midwest region, which is where I'm talking to you from this evening. University Hospital Limerick is the Model 4 hospital there, but it's made up of 3 counties, or we have North Tip, we don't have South Tip in the region. We have Limerick, and we have Clare, represented there by the Cliffs of Moher. So I have to say, it's a place I love practicing because we get a great urban and rural mix, and it's a place where our hospital group is exactly the same area as our community organization. So it has a very tight-knit feel to it, which is very helpful in managing chronic conditions, of course, cystic fibrosis being one of them. So just to start, cystic fibrosis related diabetes, to take it back just at a slightly different level, what is diabetes? So diabetes, put simply, is when your blood sugar is high. Blood sugar comes from energy. Your insulin that your body produces allows you to use that sugar and take it up into the body's tissue, where it's used in multiple processes across the body. So everyone needs it. Everyone needs glucose and everyone needs insulin. Your blood sugar, your body's incredibly good at managing it usually. So your blood sugar would normally sit between 3 and 7. The brain functions off this very, very well. Your brain tissue will only work off glucose, it won't work off other fuel. So it's incredibly important that we keep the blood sugars at a reasonable level, but not too high. And over time, if your blood sugars are in the normal range in general, you don't see any what we would call diabetes-related complications. Complications, I won't go into it in detail because this is largely to do with type 1 and type 2 diabetes. When the sugar in your blood is high, as you can see there on the left, the blood vessels, it's like aging prematurely, essentially. The blood sugars cause an inflammatory reaction in the blood vessels. They do it in very small blood vessels, in your eyes, your feet, your kidneys, or larger blood vessels, the heart and the arteries in the neck. And that's in type 1 and type 2 diabetes in particular. And this is why we worry about diabetes at all. But type 1 and type 2 are by no means the only type of diabetes, and that's not what we want to talk about this evening. Gestational diabetes is diabetes that arises in pregnancy. It's the next most common one. And we have lots of specific types of diabetes, more and more as time goes by. But we're going to talk about cystic fibrosis related diabetes. And in particular, we're going to talk about why we recognize it, why we treat it, how we treat it, and perhaps what the future holds. So what is it? Well, it's common. As you can see here, these are figures from the latest review from the Pediatric Diabetes Society. I should point out I deal with adults myself, but the pediatric journals carry an awful lot of data on cystic fibrosis diabetes, so it's very relevant for us in the adult service too. But basically you can see here that as you get older, your chances of getting diabetes, cystic fibrosis related diabetes, go up. So over the age of 40 there, you can see a little over 50% of adults carry a diagnosis of cystic fibrosis related diabetes. And that's actually very much reflective of our adult service here. Our figures are about 50% or so. It does depend also on the genetic mutation you have, and some carry a higher risk than that. But overall, you're looking at a little over 50% by the age of 40 or so. So what causes it? Well, you know, cystic fibrosis, the key problem is in the lungs when we talk about cystic fibrosis. But for cystic fibrosis related diabetes, we're talking about the issues with the gut, and in particular the pancreas. Now, how do we diagnose it? The diagnosis is not as clear-cut as type 1 and type 2 diabetes. Type 1 and type 2 diabetes also reflect a problem with the pancreas, but in quite a different way. So does it make sense for us to take the figures we use for type 1 and type 2 diabetes and apply them to cystic fibrosis related diabetes? Well, let's see. When you have type 1 diabetes, it's normally pretty easy to diagnose. Your blood sugars are usually very high, often high teens, 20s. And most people coming to us with type 1 diabetes will have symptoms. They'll be very thirsty, they'll be passing lots of urine, and they'll be losing a lot of weight as well. Type 2 diabetes, sometimes we see that, but more commonly we see that people have had blood tests done and they either have a fasting blood sugar over 7 or a glucose of 11.1 after drinking 75 grams of glucose. Now, HbA1c is something that we'll mention as well. It's very important in type 1 and type 2 diabetes, but it comes with some caveats in cystic fibrosis related diabetes. Basically, what's a HbA1c? You have red blood cells and they carry hemoglobin, and that's the HB part. The A1C is a measure of basically how sugary that red blood cell gets. And the more sugar you have in your blood, the more sugar you'll have in your red blood cells. And we have a nice way of measuring that in the lab, so you can get that easily. And we get figures on it, and the higher the figure, the more sugar in the blood on average. And because red blood cells live for about 3 months or so, you get to tell what the average sugar is over the last 3 months. But that's not always the case, and cystic fibrosis is one of the conditions where that may not be the case. So it's one of the more common things we see in people who don't deal with diabetes or cystic fibrosis related diabetes, that they look at the HbA1c and think, oh, that's okay. But we can see coming up here that that's not always the case. So, so why these criteria at all? The HbA1c you can see over there is 48. Well, for diabetes in general, it's because this is many years ago. This was published in 2003, but the figures are actually much older. A big group of experts around the world sat down in a room and had to decide, well, what's diabetes and what isn't. And the figures they took, you can see that line taking a big jump there. The figures they took were where diabetes-related eye disease became much more common. Now, does that make sense for cystic fibrosis-related diabetes? Well, the aims of treatment are different. In type 1 and type 2 diabetes, we do have very much of a focus on looking at eye complications, kidney complications, and nerve complications. We do that in cystic fibrosis-related diabetes too, but it's not actually our primary concern. So, does it make sense to pull these figures across and say, well, this is the same? Probably not. Fasting glucose of over 7, if you just relied on that alone, as we often do in the general adult population, you'll miss half of people with cystic fibrosis-related diabetes. The 2-hour, we do obviously pick people up on that, since it's part of the diagnosis. But if you take a HbA1c of 48, which again is one of the other criteria, you're going to miss loads of people with cystic fibrosis-related diabetes. So these figures do apply, but you have to be aware that they were never designed to look at cystic fibrosis-related diabetes, and you have to be aware of the limitations of them. So you have to know that the glucose pattern is different, that you can have very significant rises in the blood sugar, yet your fasting blood sugar can be just fine. And the aim of treatment is different. So your main immediate concern is not the complications with the eyes, the kidneys, and the feet, although that's something we very much have an eye on further down the line. But it's actually looking at nutritional factors and the lungs, which I'll come to again. But nonetheless, we take these figures and we apply them for a diagnosis of CF-related diabetes. And we recommend a 75-gram glucose tolerance test once a year from the age of 10. And so what is that? Well, you'd see here, you fast for 8 to 12 hours. You take a Rapalose drink. Now that's just 75 grams of sugar, glucose. You wait 2 hours, and then you get classified into diabetes, normal, or indeterminate or impaired glucose tolerance. And the indeterminate is actually a classification that's pretty much unique to CF-related diabetes, where your blood sugar, if you measure it at, for example, 1 hour, it might be greater than 11.1, but the other two are okay. And exactly what to do with that is not entirely clear. Sometimes in some centers around the world treat it. We don't actually measure the 1 hour here generally, but there's some small amount of evidence to at least consider the possibility of treating. So from 10 years old, and another thing, I won't go into this in too much detail, but continuous glucose monitoring. So self-monitoring of blood glucose would be our normal way of checking the blood sugars, where you check your blood sugars and you fill out a diary and you get this kind of pattern. Whereas continuous glucose monitoring, which is a little sensor in the skin, transmits these lovely readings and tell you what's going on in between. And you can see you might have your points where you check your blood sugars, but actually what's in between tells a whole different story. I won't go into it in too much detail because I think we're going to be talking about that in one of the other presentations. So would this be a good idea for diagnosing cystic fibrosis-related diabetes? It's not part of the criteria, but it does have good correlation with glucose tolerance test measures. And it might be a useful tool to when people are diagnosed, but in terms of actually diagnosing people, it's not something we would hang our hat on at the moment. So what causes cystic fibrosis-related diabetes? Now we know what it is and how to diagnose it. Well, exocrine pancreas disease is what you would is the traditional thinking on it. That's the gut-related hormones in the pancreas that the release of those is impaired, and it affects the release of insulin from the insulin-producing areas of the pancreas. And I suppose it's important to say that the insulin-producing areas of the pancreas are only a tiny, tiny part of the pancreas. They're less than 1% if you added them all up and weighed them, but the impact is big. But this isn't the only story. I won't go into this in detail, but basically this diagram says that there's a lot of different things that go into creating cystic fibrosis related diabetes and the problems that go with it. So to bring it back to usual type 1 and type 2 diabetes, looking at type 2 diabetes, over time, what you have, the red line is your need for insulin, and the green line is how much insulin you're producing. And you can see over time with type 2 diabetes, what happens is your need for insulin goes up a little, then stays roughly the same, but your ability to produce it falls off. And when it does, your blood sugar goes up, and you go from normal here to impaired glucose tolerance, which is kind of pre-diabetes, and then into type 2 diabetes. So is that the same with cystic fibrosis related diabetes? Not quite. It's not that different either, though, in that there is an amount of insulin resistance, but the main issue is that the green line is falling off. So the insulin production is falling off. But you have a lot of other things in the mix. You have the need for insulin going up because of infections, inflammation, and steroid use. And you also have that green line falling off faster than it might do because of mucus problems, fibrosis, and also genetic factors. So you may carry genes that also make you more likely to get type 2 diabetes. Now, you may not see type 2 diabetes, but what you might see is that for any given requirement for insulin, your pancreas may not produce as much, and you may be genetically programmed in that way. These genes are really, really common. They're spread widely throughout the population. So they'll certainly be present in people who also have CF genes as well. So it's a complex picture, and you do need this in your head when you're looking at how to treat it, because it's not the same as type 2 diabetes. It's not the same as type 1 diabetes. It's much more complex than that. So how do we treat it? Well, when it comes to treatment, insulin is the mainstay. So you can see that green line falling off, and you're not producing as much insulin as you should or for your needs. And we replace that basically with insulin. Other agents, that's one of the comments we get sometimes. Other agents, could you use tablets? Glucophage is a common tablet, metformin. There's other ones called repaglinide, which have been tried before because they give you a short little burst of insulin. I think they might be good in CF-related diabetes. But the results are fairly disappointing. And clinical trials have looked at repaglinide in particular, which is novo norm. We don't see it much in other types of diabetes, but the evidence is poor, so we don't use it. And what you really want, again, I'll come to the aims of treatment, but you do want the kind of anabolic effects of the insulin. So insulin is the mainstay of treatment. Typical regimen, what is it? Well, it depends on the profile. You have to be aware of the type of insulin you're using, and I know that's going to be covered again. Bolus, so what's that? We always use bolus, or almost always use bolus, and that's a short little burst of insulin with your meal. And basal, that's the background. That's a little bit of insulin in the background that keeps you steady all the time. So somebody might need mealtime insulin, but may not need the background insulin. An insulin pump is just another way of delivering that. So we do give insulin. We try and we try and give a reasonable dose of insulin. So in type 2 diabetes, for example, you go to a blood sugar target. In cystic fibrosis related diabetes, you want to make sure you're giving adequate insulin while not sending somebody low. So it's a slightly different way of approaching the same issue. Tube feeding, NG, that's NG there. Enteral feeding, that has other challenges as well. So matching an overnight feed, for example, will require a different way of giving insulin, which again, I think we'll cover later. Steroids will make you a little bit insulin resistant, but will also inhibit the release of your own insulin. So you generally need quite a bit more insulin when you're on steroids, and exacerbations, if you have infection, that's going to increase your need for insulin. So treatment may be intermittent. Now, often it isn't. Once we started, we tend to keep on going, even if the dose is different. But we do have situations in which we might treat during an exacerbation, and when the exacerbation settles, treatment may not be necessary for another little while. Practical aspects, in terms of the benefits of treatment, we talked about the other types of diabetes and the complications, the eyes, kidneys, and the feet. We do want to screen for them. Other complications with the heart and the blood vessels in the neck, they're less of a concern. They're very rarely reported in this type of diabetes. So we do want to screen for the complications, but actually this is our major aim. So you want to look at nutritional status and lung function, and the high sugars that you see in CF-related diabetes do impair lung function and may increase the risk of infection. Nutritional status, and again, I'm conscious that we'll be talking about this in more detail, but this is a huge part of it as well. We want to try and address the catabolic, the kind of breakdown states of that you see, and we want to build up weight and we want to build up nutrition, and insulin is a good way to do this. I won't go into this in detail. I know Linda's going to cover it, but one of the things we're very careful of is when we're in the clinic, that we want to impress on the doctors seeing the patients in the clinic that this is not like other forms of diabetes. There's a completely different dietary approach to it. And that's just a diagram illustrating what your normal pancreas would do. But again, I think we're going to cover the actions of the insulin here, but basically they're the short-acting insulins and a little bit of long-acting in the background. And when we put them together, we try and reproduce what the pancreas would normally do. So basically, cystic fibrosis related diabetes, what is it? It's diabetes. We define it in the same way. It's for better or worse, we define it in the same way. There's certainly arguments to be made for not having the same cutoffs. Nonetheless, that's what we do, but you have to be very aware when you're treating it that the approach is different and your aims are different. It's common, affecting over half the adult population with cystic fibrosis. What causes it? Basically, the pancreatic problems mean that you can't meet the demand for extra insulin, and this is exacerbated by some of the things that you see in cystic fibrosis, such as infections, steroid use, etc. And how do we treat it? Again, insulin is the mainstay. So what does the future hold? Well, the oral agents haven't been promising. So I think insulin is going to be here to stay, but how we deliver it and how we monitor it are probably where the big advances are. And really, we're in the very early days of the new CF drugs. So the impact that they will have in cystic fibrosis related diabetes isn't clear. We can see from some very small amounts of data that it improves the secretion of insulin, but it doesn't. That very small amount of data doesn't show that it reverses the other issues. So I'll be very happy to take any questions. I know we're going on through the next couple of talks, so looking forward to any questions you might have. Thanks, Keith.
No, super, great presentation, Alan. Thank you very much indeed. And I think you have answered one of the end stage questions, which is in relation to the CFR medicines and the impact they'll have on CFRD. But we can take that with Linda and indeed with Siobhan at the end, and maybe have just a slightly further discussion about it. But we'll go through Linda and Siobhan, and then on, if you're okay to stay on until just before the hour, we'll have the sort of the 5-10 minute Q&A. But now, yes, thank you very much. And I guess everything that you're talking about is really around, again, diet management and how the insulin impacts it and everything in terms of being very cyclical. Linda, no doubt, is much more of an expert on this than I am, so I'm not even going to start to ad lib. Linda, are you with us?
Now.
There you go.
Yes.
How
are you?
Now we're in it. Yeah, good to see you. Thanks so much for joining us. So Linda, yeah, great to have you with us, and thanks for taking the time. a lot of interested participants. So without further ado, I'll let you carry on from Owen's train of thought, and thanks for taking us through your presentation.
That's brilliant. Thanks a million. I think Nuala might be going to help me share my screen now. So while I'm waiting for that, there we go. I'll just introduce myself. My name is Linda O'Shaughnessy, and I've worked as a senior dietitian in CF and DIN since about 2007. So I suppose I feel I've seen a lot in the last 14 years and how things have changed. And I suppose a lot of my presentation today probably will relate a little bit to maybe how we're going to have to rethink what we're saying a little bit, and how we probably need to take quite an individualized approach to the dietary management of both CF and patients with CF-RD. So now I apologize because I can't seem to change. Oh wait, there we go. It's just a bit slow. So this table was taken from a very recent paper. Well, it was from 2019, and it was looking at nutrition and growth considerations in CF, and it was written by Kadinsky. And I suppose the underlying message is similar to what Owen was saying, that it's the priority in CF-RD and diet is to focus on attaining optimal growth in children, and to make sure that in adults that they're attaining an appropriate body weight. We know, and I'll touch on this later, that weight and lung function are very closely linked. And I'm just going to move on to the next slide because that one is actually really difficult to read. But I suppose the premise has always been that we want patients with CF-related diabetes to have the same nutritional status as those without CF-related diabetes, so the other CF patients. But I suppose as I'm beginning to see the effect of the modulators, I am beginning to wonder if we should be moving slightly away from the free-for-all attitude of being able to have whatever they want and that will match it with insulin. So I know this is probably quite surprising coming from me, because I've probably stuck very strongly to the other mantra for a long time. So for a moment, I just want to look at what we're aiming for around nutrition in CF patients in general, and I suppose what a little bit of the emerging evidence are coming, or what we're looking at, and then I'll come back to looking at maybe the guidelines around CF-RD. So this is probably one of my favorite graphs. Along the bottom, we have BMI, which is a measure of our weight for our height. It's called body mass index. I suspect anyone who attends a CF clinic is very familiar with the term. And on the vertical axis, or the axis going up, is FEV1, which again is something I suspect everyone's very familiar with, a measure of lung function. And between 18.5 to 25 is considered normal. And as you can see, there's what we call an exponential increase in lung function as BMI goes up. So this is where we get the data. It's taken from the CF Foundation, where the ideal BMI in women is 22 and for men is 23. But as you can see, as BMI goes up, the rate of increase of FEV1 begins to slow off. And this has been reproduced by lots and lots of other people. So I guess we are beginning to see that with BMI, it's not a case of the more the better, that it probably is a case of attaining up to an ideal body weight or a BMI of 22 or 23 and trying to maintain it between there and the upper end of a recommended range up to 25. So we're setting our standards very high, but I suppose we know that a healthy normal BMI is what's best in CF patients. But as we all know, or as people may have heard, BMI isn't the be all and end all. And what BMI is made up of, whether it's made up of muscle like the gentleman on the left, or fat like the gentleman on the right, that probably does have an impact, but we haven't really teased out how it affects us. So obviously, if someone plays rugby for Ireland and has a BMI of 35, they're a very fit, very healthy person. So we can't just use BMI alone. What we do need to look at is what is the composition of that weight. So whether it's a mixture of muscle or fat, or how that balances out. And I suppose there's emerging evidence that tells us, so looking at these graphs on this side, we can see FEV1 versus BMI, and we see the shape of the graph that we recognize, where the higher the BMI, the higher the FEV1, whereas in the same group of patients on the left-hand graph, we can see that the higher, that we have body fat along the bottom this time, and FEV1 still going up. So we can see that the higher the body fat is, the lower the FEV1. So I suppose we still don't have enough data to be able to absolutely understand the role of body composition in CF, but we're beginning to understand that it probably does have an effect. And I suppose many of you will have experienced maybe quite rapid weight gain since starting a modulator, and perhaps a lot of that weight has gone on as fat. So I suspect it's something that may ring true with a lot of particularly adult patients. So it's something that we do need to be mindful of, particularly in the current environment where we have very rapid progression of nutrition and weight in patients who started highly effective modulators. So now I want to come back to the guidelines. And I suppose the truth is, for a long time, patients with CF absolutely needed up to 1.5 times, or often like twice or more than twice the calories of a non-CF person. But now we're probably beginning to see that that isn't the case for everybody, and that some people will have a requirement much closer to patients without CF. So I guess it's just to bear that in mind. I also need to say that, like, I work solely in adults, and I think the role of growth in children can't be underestimated, so that it's really important to make sure that when you're looking at how many calories your child needs, that you're taking into account the growth along the charts. I'm going to come back about carbohydrate and fat, because I think we probably do need a slightly more individualized approach. And just down under special circumstances, that previously it was recommended for no weight loss. And these guidelines were written, the CFRD ones are from a very important paper in 2010, where we re-looked at how we diagnose CFRD, and it stressed the importance of treating it with insulin, as Owen has covered. But I think at the moment it is probably fair to say that weight loss is indicated in some cases, and that, you know, we are trying to work closely with patients to try and, I suppose, limit any weight gain with the modulator, so that they don't go from a healthy weight up to an overweight range. That we want to kind of optimize body composition and nutritional status without perhaps paving the way for problems further down the line that I suppose nobody really knows about yet. So I'm going to just come back and look at the carbohydrates and the fats a little bit. So I think historically we would never really have recommended whole grains in CF. But I do think that if it's something that people feel that they can tolerate with their gut, then it's a good thing to include brown bread, brown pasta and brown rice. If it doesn't cause issues with constipation, it is of benefit to the gut. Previously, we probably wouldn't have encouraged very many fruit and vegetables because they aren't very calorie dense foods. But again, definitely they are something that can be included and should be included in patients' diets. When we're looking at the fat, previously there was absolutely no restriction on fat, and we just matched it to Creon. And I suppose there is no link at the moment between cardiovascular disease and CF. It's something we don't know anything about, but I think it is sensible for people to start to include healthier fats in their diets. Things like oily fish, nuts, seeds, vegetable oils and avocados would be good examples of them. I know Owen mentioned this as well. I have a real thing about refined carbohydrates, so things like fizzy drinks and jellies. They provide no nutritional value. They're terrible for people's teeth. And they cause havoc with most people's blood sugars, even without an underlying diagnosis of diabetes. They cause a really sharp spike in sugars quickly after drinking them. So I would suggest to avoid them if at all possible. I'd also recommend working closely with physiotherapists if body composition is something that needs to be looked at. I know the physios in Vincent's have a YouTube channel set up, and they have some really great strength training programs on it, specifically aimed for people with CF, and that kind of are tiered for different people's ability. And not to be afraid to address overweight or obesity if it is an issue for you, that there's lots of support from dietitians within every service to be able to help you to look and manage this. So I suppose ultimately the idea behind a diet for CF related diabetes isn't any different than it used to be, in that we still want people to attain an ideal body weight. And it just a diagnosis of CF/ORD doesn't mean that you need to change what you're eating. It just means you need to continue to try and optimize your nutritional composition. And if that does involve addressing overweight or obesity or looking at body composition, then that's something that the dietitians will be very happy to work with you. But I suppose just to bear in mind that there's also lots of people who still aren't achieving an ideal body weight or BMI, and that I guess we now have like a split role that we have to try and balance. So one of the things I think is important is just to look at how insulin helps us achieve these goals. And Owen has mentioned how insulin is an anabolic agent. It helps us to build muscle, and without adequate insulin, we aren't able to grow, we aren't able to gain weight, and we aren't able to make muscle if changing our body composition is one of our priorities. So I think Owen has covered a lot of this, but I just wanted to talk a little bit about the slide. I hope people can read it, the sources of carbohydrates. So they can come from, and I suppose the idea is that understanding what carbohydrates are and how they work in our body helps us to understand how to take insulin and how to adapt it. I'm touching on this very briefly today because like this can be a whole week-long course run for people with type 1 diabetes, where they come and they learn how to count carbohydrates appropriately. And so this is just like a little taster to help perhaps people understand why carbohydrates are important to understand. So they come from starchy foods like bread, rice, potatoes, pasta. They also come from sugary foods, foods with added sugar like jam and jelly and biscuits and cakes. And then they also occur naturally in some foods like fruits, yogurts and milk. And regardless of where the carbohydrate actually comes from, it's broken down into glucose in the blood. And then for people without any diabetes, they make an appropriate amount of insulin to take that glucose and bring it into our muscle cells so we can use it appropriately. And insulin is like the key. When there is a diagnosis of diabetes, be that CF-related diabetes, type 1 diabetes, type 2 diabetes, or gestational diabetes, the glucose stays in the blood because there isn't adequate insulin to match it. So one of the important roles that endocrine teams and dietitians have with patients with diabetes and CF/ORD is among that, is helping them understand how to calculate what carbohydrates they've eaten so they understand how much insulin to take. And I know that probably sounds a little bit complicated, but I think patients with CF adjust to this brilliantly because they're so used to adjusting their creon to their fat intake, and the premise is actually really, really similar. So this is a graph very similar to what Owen showed us, but yeah, we give insulin at the times when we eat. We know that 10 grams of carbohydrate will put up a blood sugar by 2 to 3 millimoles. And I guess the way you count and calculate, I'm going to skip over these slides because I know I won't have time. The way that you count and calculate the carbohydrate content of foods, as I said, it is complicated. It takes a lot of work, but it's 100% worth it because it gives you a lot of control over your diabetes. Weighing foods and reading food labels is probably the most accurate way to do it. The Tesco website is of immense value to me, and I'm sure it can be to you. It has the nutritional composition of all foods that they sell in Tesco. So if you've put the label in the bin, it'll save you having to go hunting for it. And then there's some apps. Carbs and Cals, I'm going to just show you a little bit from that because I actually think it's a really, really beneficial app. And you can also, if you're not tech savvy, which I presume everyone on an online conference is, you can also buy a book. So the app costs £5 and it is really worth it because of the amount of information that you can get from it. And the book is about €15 and can be bought online. There's also My Fitness Pal, which is free, but I suppose I just have a lot of reservations about My Fitness Pal in that we don't know, you know, you put in a scone or a banana and you get like 15 different options with 15 different nutritional composition. And, you know, it's very difficult to figure out how that computes to what's on the plate in front of you. So just to go back a little bit to carbs and cals, I suppose this is the kind of information that it will give you. So if you put in a bowl of cornflakes, it actually gives you 6 different pictures of bowls of cornflakes. So as you can see, this one you can see that there is a 20-gram difference in the bowls of the amount of carbohydrates in them. So if you got your insulin wrong, you could have a difference of like 6 millimoles. It could end up being 6 millimoles higher after you've eaten if you got the count wrong, which can be really frustrating for someone with insulin when they've spent the time trying to figure out how much they need. Or similarly, like a banana, unfortunately, is not just a banana. You know, there's double of the carbohydrates in the one on the right than there is on the left. Or mashed potatoes. So these are just some examples of how, I suppose, that carb counting can be really valuable in learning how to do and learning how to do correctly, but that it is like, it's a challenging thing to do. So I suppose I know that I probably have run out of time, so I'm going to finish here, and I'll be happy to answer any questions, and I'm happy to make my slides available, and because there's some information on some of them around what carbohydrates are and what they aren't, and how to manage around exercise, which may be useful to some people.
Very good. Thank you so much. That was really interesting, Linda, and I definitely know I need to watch my my mashed potato protein, or sorry, portion size now when you show you that picture on the plate. But no, really, really interesting, and lots of, I think there's perhaps a little bit of overlap. Thanks for keeping an eye on the clock, because I know I'm mindful that we want to try and make sure we get people out to their dinner if they haven't had it yet. So if you could stay on as well, Linda, we'll come to Q&A for the last 10 minutes or so. Siobhan, that's putting you on the clock now.
Yeah.
In that you can blame Linda and Owen for robbing your time. But if we can keep it to 9 minutes or so, if we can aim for that, and then we'll bring 10 minutes up for Q&A. Is that going to put you under pressure?
It will, but sure, listen, I can share my slides as well at the end. That's no problem.
See how you go. Yeah, but yeah. I guess that's just in fairness to the audience.
Okay.
But yeah, thanks so much for joining us, and over to you.
So my name's Siobhan. I'm one of the diabetes nurses in Vincent's, and I specialise in CF diabetes. I started my role back there in 2015. So I suppose I'm going to fly through my slides, but I did want to point out just who is involved in the diabetes care, that you do have your diabetes consultant, the diabetes nurse, a dietitian. Some people may need to see a podiatrist, and you also have your CF team involved there as well. But the person who's most involved in your diabetes is always going to be you, the person with CF and diabetes. And it's really important that you communicate with the team, especially if there's things that are bothering you, because there could be things that we could help to improve, like be it new devices or changing your insulin regimes to work a bit better for you. So I did want to put this at the beginning, because I know there's a lot, when my patients come into me, I suppose a lot of the time we're talking about how they feel about their diabetes, because it is really common to have negative feelings towards your diabetes. Some people can say that they're feeling very angry or frustrated, or have a lot of resentment towards their diabetes. And I did want to mention that it is, the diabetes team understands that living with diabetes and CF is really hard and frustrating, but they are there to help you and to try and work with you to try and improve things for you. As I said, there's different devices, different insulin regimes, or maybe it's just trying to get the psychological support of having these two illnesses together. So we did mention glucose monitoring between Linda and so we do recommend that you check your sugars before meals, and we recommend that they're between 4 and 7. Some of the centres will recommend that you check 2 hours after meals, and this will all depend on your local diabetes recommendations. We ask that you check before and post physio or exercise. This is also to help us to explain to you how to adjust your insulin for your exercise. It's really important as well that you check before driving. And if you are on feeds, we do get you to check before your feed, in the middle of your feed, once to twice per month, or if you're more frequently if you're adjusting, and after your feeds. And technology is completely changing constantly in diabetes, and there's lots of new meters out there and apps which will help you. So there's some apps on the phones that your meter will automatically upload to, and it will give you an idea. Sometimes it will indicate if you're going high at certain areas, and will give you kind of a prompt to contact your diabetes team, and you can actually send your logbook in by email to your diabetes nurse, which is very helpful. There are other newer devices that you may have heard in social media or through the media itself, called continuous glucose monitors, which Dr. Noctor there mentioned earlier. So these are sensors that you can wear in your arm or your tummy, and each certain sensors will actually send an alarm sometimes if you are going to be going low. So if your blood sugar is dropping less than 4. These devices will allow you to share your data directly with your diabetes team, or you can decide to share it with your family or friends if you want to. It's really important to mention that these devices are all funded by the HSE, and there's a strict clinical need that has to be met for them. So it's really important that you discuss these options with your diabetes team to see if you're eligible for it. So there's a few, you can see there down below, I've just put it down a graph. So it gives you an idea of how much information we actually get from these sensors. And I find them really helpful for people who are on feeds overnight, so we can get lots of information and adjust the insulin accordingly for it. So as Linda and Owen had mentioned there, CF diabetes is very unique, and it's really important to remember that the advice that I might give you would be very different to somebody else who has diabetes with CF as well, because it's all very much tailored towards you. It's very different to type 1 and type 2 diabetes. I do always mention not to be looking up the type 1 information and type 2 diabetes information, to remember that your diabetes is very different to this. So insulin, I wanted to go through a few kind of do's and don'ts about insulin, because sometimes I think we forget, and we need to always go back to the basics to see, well, are we giving the insulin right? So we do recommend that your insulin needle length is between 4 millimeters and 6 millimeters. And the needle should be injected at a 90-degree angle, and it should be left in for 10 seconds. This is to allow the insulin to be absorbed from the needle. It's really important that you don't go in at a 45-degree angle, because the needles are designed that they just go under the dermis and into your subcutaneous tissue. The needles should only be used once and should be disposed of immediately in sharp spins. I see this happen loads, that people reuse the needles, and I can understand that when you're out and about. But what happens is when you put those needles under a microscope, those needles can bend and they become fish hooks, and they can actually start to damage your injection sites and cause more problems later on. So do just use the needles once. We don't recommend that you disinfect the injection site. It's not required to do so unless your diabetes team really want you to. Never inject through clothing. That's something else I kind of see when people are out and busy. What can happen is, as I said, you can get little fibers and things like that, and it could damage your injection sites. And then just, you can see in the little picture down there, we do recommend that children or people who have low BMIs of less than 19, that they use a skin fold just to get the insulin into the subcutaneous tissue. So the insulin can be stored at room temperature once it's in use, and it should only be in use for 1 month. After that, you should throw it away. And insulin that's not in use can be stored in the fridge, but not too close to the back, because it could freeze and then it won't work as well. And never store your insulin needle pen with the needle attached. So there are different types of insulin. A lot of people will be on mealtime insulins, and this should be used with meals and snacks that contain a carbohydrate, like Linda was speaking about earlier. We do advise that you take that insulin about 15 minutes before a meal when it's possible. It's not always going to be possible. There could be instances that you might need to take it after a meal if you're not feeling well and you're not sure how much you're going to eat, or if you've gone to a restaurant and you're not sure when the food's going to be there. So it's always important to remember to keep yourself safe, but when it is possible, try and take that insulin 15 minutes before the meal, so it's working the best for you. There's also long-acting insulins there that some people may be on, and it can be taken once or twice daily, but not everyone with CF diabetes is going to require a long-acting insulin. And we also have mixed insulins and intermediate insulins, and these would be commonly used with feeds, or if you're going to school, they might put you onto a mixed insulin if you don't want to take insulin in the middle of the day. So I've just put in a little diagram. I think Linda and Owen put in some good ones as well, but I just wanted to bring everyone's attention just to the rapid acting insulins. That's your Nova Rapid, Humalog, Epidra, or Fias, and it starts working within after 15 minutes, and it peaks about 90 minutes, but then it is out of your system within 4 hours. But it's really important to remember this, just if you are taking this quite frequently, that the insulin will be in your system for 4 hours. I wanted to talk a little bit about insulin pumps, because I know that there's been a lot of this in the media recently about closed loop systems. So the insulin pumps are small programmable battery powered devices that deliver insulin continuously, and it does require intensive education. It's not necessarily for everyone, because it does require a lot of education. In my experience, I've used the insulin pumps with people with CF, on people who have feeds overnight, because I feel like they work really well for that. So one of the common side effects from insulin is that if you're going to injecting into the same area all the time, is that you might get a fatty lump that can appear on the surface of the skin. Insulin injected into these lumpy areas may not be absorbed correctly, and it can actually cause a high blood sugar or low blood sugar. The best way to prevent these from happening is to rotate your insulin injections around your abdomen or your thighs, always using your needle and never inject through clothing. So when you do come into the diabetes clinic or you meet your diabetes nurse, your injection sites will be checked and you'll be advised if you need to avoid certain areas. So hyperglycemia or high blood sugar levels, it's really important to remember there's lots of reasons why you might get high blood sugar levels. You may have an infection at the moment, you may be having a lot of stress from exams, or you may have eaten too much without the correct dose of insulin, or you may have over-treated a low blood sugar, or for children, they may be going through growth spurts, and it's important to remember that as well. So what should you do if you do notice a high blood sugar level? Is that you should really talk to your diabetes team, because you will need an adjustment in your insulin, and they're the best ones to advise you. So get on the phone or email and just get in touch with your diabetes nurse or your diabetes team. So hypoglycemia or low blood sugars. So I'm sure if you have diabetes, you've probably experienced a low blood sugar at some point. And this is when your blood sugars drop less than 4. So you can start to feel very weak or hungry or feeling shaky. Some people feel sweaty, or for some people, they just don't have any change in their any symptoms. So when they check their blood sugars, they can be quite surprised. The reasons why you might have a hypo is if you took too much insulin, or maybe you had some unplanned activity that you hadn't taken account for. You may have taken a little less carbohydrate at a planned meal, or you were in a restaurant and your meal didn't come on time, or you had excess alcohol. If you do have any low blood sugar feelings, it's really important that you check your sugar straight away. And if your sugar is less than 4, you act immediately. So you need to take about 15 to 20 grams of a rapidly absorbed carbohydrate. And there's a list down here below. A lot of people will choose to take the Lift glucose shot, which is available on your long-term illness. So you need to get a prescription from your diabetes team for that. Or you might take the Coca-Colas, that you can get the mini cans. So it's about 150 to 200 mils, but just with the Coca-Colas and 7-Ups and things like that, you need to be careful because they are reformulating the amount of sugar that's in them. So just be careful because they are reducing that. So a lot of people would go for the fruit cartons that you can get, which are about 200 mils. It's really important that you do check your sugars like 10-15 minutes after you have a low. And if it is still below 4, that you treat it again. So you take another Lift shot or another carton of orange juice. If it is above 4, then you can have your snack. So you can have a slice of bread, a biscuit, or a yogurt or something like that. For some people, the diabetes team may prescribe a glucogen hypo kit, and this is in case of a severe hypo, where you might go unconscious, so you might need assistance to get yourself out of that hypo. So glucogen is an injection of glucagon, which works by triggering the liver to release its stored sugar, which will raise your blood sugar levels. It's very similar to how your insulin injection is, but your diabetes nurse will talk to your family or friends and show them how to do this injection themselves. How am I doing for time? So with diabetes and driving, if you're on insulin, you need to inform your driving licensing authority and your car insurance company as well, just to make sure that you are covered for driving. Before driving, you should always check your blood sugar level and ensure it is above 5. Check your glucose levels every 2 hours if you're going on a long journey, and always keep something in your glove compartment that could treat a hypo. So again, a lot of people have either the glucosate sweets or dextrose sweets or the Lift glucose shot that you can have. If you do have a low blood sugar when you're driving, it's really important that you pull over, turn off the engine, remove the keys from the ignition and move it from the driver's seat. You need to treat the hypo appropriately, but then what's really important is that you don't drive for 45 minutes after a low blood sugar, because it takes this long for your brain to recover. So from diabetes and just school, because I know there's probably a lot of people who are here still in school, it's really important that your school principal and class teacher are aware that you have diabetes and that you provide them with written or verbal information on what to do if you have a low blood sugar. What some people find really beneficial is if you create a little pack with hypo treatments in it and an information leaflet as to what to do with it for the class to have. And if you do have younger children, it's really important to remind them they have to finish their lunches. I know they get very distracted by playtimes and things like that, and they tend to run out and forget that they need to finish their lunches and end up having a low blood sugar then. And if you want, there are school resource packs on diabetesireland.ie. So just a little bit on diabetes and alcohol. Alcohol can cause low blood sugars. The liver will store extra glucose, which is released into the blood sugars, into your blood when your blood sugars drop. And alcohol will affect the liver's ability to actually do this effectively. And it's more likely to happen if you drink to the excess. So do remember that alcohol can cause low blood sugars for up to 24 hours. So do remember that. And if you have been drinking to the excess, make sure you have a snack going to bed. Okay. And a few other points there, but Keith, do you want me to finish up?
Yeah, just, well, I know there's lots that you probably still wanted to cover, and sorry for putting you under time pressure. I'm just mindful we only have a couple of minutes left, and there's a couple of questions that have come in there, Siobhan, even a couple for yourself with Linda and Owen as well. So I guess what we'll do is we'll circulate the slides, Siobhan, as you said, which is great, and lots of really important info. As you said, there's lots of different groups on here, people with CF parents, and associated members. But if it's okay, I'll fire through a couple of the questions that have come in to the panel, and then we'll get everybody out just after the hour. So starting, it should be good if I had them open, wouldn't it? No, now you're putting me under pressure. That's what I get, Siobhan, for telling you only had 9 minutes. So I guess the first question really is just, again, I'm not sure who wants to take these or how you want to do it, but if an adult with cystic fibrosis is pancreatic sufficient, are they then less likely to develop CF related diabetes? Not sure if this is a round robin or who wants to take that. Owen?
Yeah, so there's the two are very much linked. I think looking at the data to see, is there any evidence that if that before you have pancreatic insufficiency, is your insulin affected? There's very, very little data on that. So if there's an effect, it seems to be small.
Okay, good. Thanks for the fast answer as well. This is efficient with our timekeeping. Next question. Having cystic fibrosis and also having CF related diabetes is a lot to manage all at once. Is there a case for insulin pumps and continuous glucose monitoring for all people with CF with diabetes, just to make things easier for us?
I think sometimes people don't realize how much work actually goes into insulin pumps. I don't know, Dr. Noctor, would you agree as well? That it doesn't actually take over your diabetes. There's a lot of work that has to go into them. For some people, actually, it would actually be a lot more pressure to have. I do think sometimes the continuous glucose monitors can make life that little bit easier. But again, for some people, all those numbers coming in can actually be a lot more overwhelming for them. So it really comes down to that person. If they feel like it could help them, then they really should talk to the diabetes team and see, can they access it? But I think with insulin pumps, it doesn't cure your diabetes. You still have to do a lot of work with it.
Very good. Yeah, fair. Thank you. The next comment is, I really appreciate the push to rethink the BMI and look at how the composition of weight is made up. How will that get measured and monitored, do you feel, in the future? Thanks also to Linda for the app suggestions. So maybe Linda, I'm not sure if that's one that you could tackle.
Answer that. So I think one of the things that's really important to say is that the evidence that we have still really, really heavily supports BMI. We're only beginning to see trends in data that suggests body composition has a role. But that said, I know on the ground, and I think I think a lot of people are experiencing the same, that there's a really rapid shift in weight gain, and we are probably in a space now where our guidelines aren't maybe totally reflecting what we're seeing in practice. So in terms of measuring body composition, DEXA is considered the gold standard, and most people have a DEXA as part of an annual review at intervals of between 1 and 5 years for assessment of bone composition and to assess for osteoporosis. So the DEXA machines, a number of them can measure body composition, so that can often be a useful add-on to the DEXA if it's being done, and lots of centres are doing that. But again, sometimes the frequency of that isn't frequent enough. Then there's a thing called BIA, or bioelectrical impedance, that can be used, and that's again, the evidence base isn't massive for it in CF, but it's probably something that can be used frequently at 3 or 6 month intervals to help people track progress that they're making. There's other things like a bod pod, or the use of calipers, where a highly trained dietitian pinches 7 points of view with the metal pinchers, which I don't think would be wildly popular, but they're the options that we have.
Sounds great fun, yeah. So we'll avoid the calipers.
Towards looking at body composition.
Okay. Yeah, no, good. The other question that just follows on there, then perhaps Sam, it's maybe in relation to the no jellies comment in your presentation. Are there any particular foods that should be predominantly avoided to prevent getting CF-related diabetes?
I think probably the idea is that CF-related diabetes happens because of a defect within the pancreas, so that the person with CF or without CF, whoever develops diabetes, or particularly in type 1 diabetes, that it's a lack of insulin that's the problem, or a resistance to insulin. Yep. So in terms of developing CF-related diabetes, unfortunately, there's no food that will stop it, yep. Or no diet that will prevent it.
Yeah, good. Super. And then one question, Owen, and I know you touched on it in your presentation, and I presume it probably just maybe brings us full circle in relation to you all as a team. Do you or any of you have any understanding of how the CFTR medicines and modulator drugs are going to have impact on CF-related diabetes? I know, and I said I'd come back to you on this one. Perhaps you could just maybe give your answer again, just to close that point off a little bit further.
Sure, yeah. With the CF modulators, the data is very limited on diabetes and the CF modulator drugs. There's a couple of small studies, and one of them does show that the insulin the amount of insulin released is improved, which, funnily enough, although it sounds like that's self-explanatory, that's not quite the same thing as translating into better blood sugars and better control. But having said that, it's very, very early days, and I don't know if Linda and Siobhan might have you have more numbers, I know, in St. Vincent's, so you might have a practical insight into things. The data doesn't say much so far, but
okay, yeah, that's fair. Thanks. Linda, Siobhan, anything to add?
I think what I find is that some people's requirements have dropped when they initially go on to the modulators, but then they start creeping up a couple of weeks or months later. And then for other people, it just seems to send them skyrocketing again. So I think it's, again, very individualized. And I just think it's still very early days. We don't really know how it's going to pan out.
Okay. Linda, anything from you, or?
No, I think I just agree. I think like the modulators are having effects that we probably didn't really anticipate, particularly around weight gain and changes in nutritional status, or effect on the gut and people's digestion. You know, we're seeing things that we didn't anticipate that we'd see, that probably were seen in too small numbers in the studies. So the truth is, we just don't know yet. It's a really exciting time, and I think, you know, the future is looking very bright with the modulators, but how they actually are going to impact on diabetes, we just don't know.
Yeah, no, I think it's a very fair answer and a great way to sort of close this off and summarize. I think the unknowns are probably something that we need to continue to investigate and continue to look into, which is why, again, from CF Ireland's perspective, we need to come back to you as a team, seek feedback on where you need further insights, further research studies. That's a lot of what CF Ireland are doing, is continuing to invest in new protocols, new studies. And as you said, Owen, the numbers aren't quite there yet. And if we can get our hands on more numbers, perhaps we can paint a better picture on how to better manage CF-related diabetes as we go forward. So I think with that, I'd like to thank you all. I know we've gone 5 minutes over. So thank you all, Owen, Siobhan, Linda, for your time this evening, and it was really great. I learned a lot. So thank you very much for sharing, and I know a lot of people on the audience screen did also learn together as well. So thank you so much for supporting us in the conference and being present this evening. So that brings to a close day one of the conference, and I unfortunately would love to go and have a couple of pints of Guinness and share a couple of jokes with you all in the bar, but we'll have to save that for next year. We covered a lot this evening. Obviously, the introduction from Philip on the progress made in the last year, the medicines, the changes, the developments in terms of everything that CF Ireland have done. We got a fantastic presentation then from Professor Paul McNally on everything to do with the modulator medicines and how they're impacting, and the positive sentiment that really came through in Paul's presentation. For me, as a father of someone living with CF, it was definitely an uplifting presentation. It was definitely something that gave a lot more hope, but it's not something that we need to rest on. We need to continue, as Paul said, to look to live and to maintain our focus on the well-being and health maintenance, were his words, health maintenance of people with cystic fibrosis. We don't have a cure for this condition, and we need to continue to invest our time and our energy in making this better for people living with cystic fibrosis. And then we've moved on then to the awards with Fergal, where he was drawing names out of a hat. My name didn't come out, unfortunately, so I don't get the Lenovo tablet. But listen, we got some great awards, some great recognition for the walk. And then we moved on to this evening session with Linda, with Siobhan, and with Dr. Owen Noctor to cover what is definitely been a topic that has been asked for a number of our members to cover, which is CF-related diabetes. So some great insights, both from Owen's viewpoint, from the condition itself, through to the management, through dietitian, and through to care, through how we manage ourselves through the condition if we live with CF-related diabetes. So a lot to fit in on a Tuesday evening, a lot to take on board, but really thank you very much from my side to the presenters, to those that put things together. Again, thanks to Nuala, to Caroline, to the team behind the scenes, to keeping this ticking over. Tomorrow evening we'll come back on at the same time, where we've got a fantastic lineup hosted by Patricia Duffy-Barber. So Patricia's going to guide us through a whole range of research topics. Professor Luke O'Neill is going to kick that off at the 5 o'clock session, always an interesting speaker. Some great research papers. I'm not going to name the doctors. And then a huge topic in the evening around parenting, pregnancy and contraception in cystic fibrosis. So lots of great topics that we need to bring on and bring to the table tomorrow evening. So tune in, same time, same place, 5 o'clock through to 8 tomorrow evening, and then we'll wrap it up with a close. But yeah, no, from my spare bedroom to you where you are, have a great evening. Thanks for tuning in, and wish you all a pleasant evening, and see you tomorrow for day 2 of the conference. Take care and all the best. Bye-bye.